Bismillahirrahmanirrahim. Now we will start the session 6 of our reproductive unit, and here we are talking about the anatomy of ureter. So the course enters the pelvis. The corset enters the pelvis by crossing the bifurcation of common iliac artery. It then passes down in front of the internal iliac vessels to become medial. No. So it enters the pelvis by crossing the bifurcation of the common iliac artery, like over them. It then passes downwards in front of the internal iliac vessels to become medial to them and behind the infundopelvic ligament, I guess. So it is happening like this, that it passes downward in front of the internal iliac vessel. As you can see over here, it is passing in front of the internal iliac vessel. This is internal iliac vessel. It is passing in front of that to become medial to them and behind the infundibulopelvic ligament. Okay, so it is basically passing behind the infundibulopelvic ligament. If we could go to the infundibulopelvic ligament table, that was somewhere over here, like here. So this is the the infundibulopelvic ligament is this one, the suspensory ligament of the ovary that connects the ovary to the lateral pelvic wall. So let's come back over to a picture. So here you can see that it passes downward in front of the internal iliac vessel and becomes medial to them and behind the infundibulopelvic ligament and ovary. It crosses by the uterine artery. It is crossed by the uterine artery at the base of the broad ligament. So it is crossed by the uterine artery at the base of the broad ligament. Okay, at the base of the broad ligament, it is crossed by the uterine artery, and the uterine artery crosses above that. Then here the ureter is 2 cm lateral to the cervix and 2 cm above the vaginal vault. 2 cm lateral to the cervix and 2 cm above the vaginal vault. So here is the cervix, so it is 2 cm lateral to that and 2 cm above the vaginal vault. I guess this is the vaginal vault or something, so I don't know. So just remember these dimensions, and then we'll move forward to the ureteral anatomy. So here in the ureteral anatomy, you can see that this is ovarian artery, the red one. Let me zoom it in. So it is, as you can see, this is the ovarian artery and the ureter is passing under that. Then these are the internal and common iliac artery above that. Then below the uterine artery, and where is superior vesical artery? Superior vesical artery, I can't see that. I guess the purple one is the superior vesical artery. So the ureter is just passing above the iliac vessels, and it is below all the rest of the structures. So you can see in this picture that this is the ureter. Okay, so ureter is passing below the gonadal arteries and veins, then above the external iliac arteries, and then it is passing the female reproductive structures are not made over here. So this is the pathway of the bladder, and then the right kidney that is a bit lower than the left kidney, and the psoas muscle is over there, common iliac artery and the internal iliac artery and everything. Pelvic imaging. So the thing about pelvic imaging that you must keep in mind is, so whenever they give you a CT scans are kind of confusing. For me, they are confusing. So maybe you are like expert of that. So this is rectus abdominis muscle that is anterior, and here we have the spine. So firstly, locate the spine to see the axis of the CT scan. By the way, most of the time this is anterior posterior, like anterior and posterior like that. They don't test you on that. So the thing that they are testing you, there will be anal canal just anterior to the vertebral body. The dark area anterior to the vertebral body will be the anal canal. Then the prostate gland is located. The first structure is the anal canal, the second structure is the prostatic gland, and the third structure that comes later on is the bladder. Okay. Then this is the ischial fossa, and then we have the gluteus maximus muscle. So they can test you on any one of them. So just keep this sketch in mind, that firstly, the very first structure, if you move in the linear direction from vertebral body towards from posterior to anterior direction, so the most adjacent structure, the closest structure, the structure in the closest proximity to the vertebral body will be the anal canal. Then comes the prostate gland, and after that we have this bladder in a linear fashion, and then it goes to the rectus abdominis muscle all the way up, all the way anteriorly. Then the ischio-anal fossa is present on either side of the anal canal, and the gluteus maximus muscle is this opacity that we find in the CT scan, like this ring shape opacity. So then we have this one. So this is a picture of the kidney. So this is transversalis fascia. Okay, The posterior renal fascia is over there. Then we have the posterior renal space, then perirenal space. The posterior renal space is located behind the kidney. Then the perirenal space is between the between this fascia like thing and kidney, and anterior pararenal space, and then we have the lateral colonic fascia, then paracolic gutters are over there, and the what is that, properitoneal flank stripe, anterior renal fascia one layer. Okay, so anterior renal fascia, and so I don't know why is it important, but these structures, so you must be able to remember that there is a pre-renal fascia. The kidney is surrounded by a fascia, remember that. Moving forward to the physiology, now here we have estrogen. So estrogen is the source is ovary, that is 17 beta estradiol, placenta, adipose tissue. So these are the three sources of production of estrogen. First one is ovary, that will produce 17 beta estradiol. Then we will have placenta, that will be producing estriol, and then adipose tissue, that will be producing estrone via aromatization. So the potency is in the order like estradiol will be most potent, then estrone from the adipose tissue, that is potent, and the least potent is the estriol coming from the placenta. Okay, then function, development of the genitalia and breast. Okay, they are responsible for the development of genitalia and breast and female fat distribution. Growth of follicle, we are talking about the function of estrogen. Okay, so firstly it is responsible for the secondary sexual characteristic, basically development of genitalia and the breast and the female fat distribution. Then growth of follicles, endometrial proliferation and increased myometrial excitability, upregulation of estrogen, LH and progesterone receptor, feedback inhibition of FSH and LH and LH cell, stimulation of the prolactin secretion. So what's about that? I just didn't get it. So they're talking that upregulation of the upregulation of the estrogen, LH and progesterone receptors will lead to a feedback inhibition of FSH and LH, and then LH surge, stimulation of the prolactin secretion. So where is estrogen? Estrogen is over here. Estrogen leads to the negative feedback inhibition of the FSH and LH, and also the GnRH. So this is clear, but what were they talking about in that point? I guess they were talking about this picture. So here you can see the estrogen is over here, and what is it doing? Estrogen, cholesterol, thicker cell, blah blah blah. So this is estrogen. So let me read that once again. So they're saying that estrogen is upregulation of the estrogen, LH and progesterone receptors will lead to feedback inhibition of FSH and LH. Okay, got it. It causes the feedback inhibition of both of them. Then LH surge, feedback inhibition of FSH and LH, and then also LH. So basically, initially estrogen is responsible for inhibition of the LH. Then LH surge is also mediated by the estrogen, and thirdly, it also stimulates the production of it also stimulates the prolactin secretion. So prolactin secretion, inhibition of FSH and LH, and also the LH surge. These three things are being mediated by the estrogen. So estrogen, upregulation of the estrogen, LH and progesterone receptors. So the thing that you must remember is that LH, this one, estrogen is responsible for all these functions. That is, it is going to cause the inhibition of FSH and LH release. Then LH surge is also dependent on estrogen and stimulation of the prolactin secretion. Increase of estrogen transport proteins and SH beta, sex hormone binding globulin. So that leads to increase in transport proteins, increase in sex hormone binding globulins, increase in HDL, and a decrease in LDL. So estrogen causes an increase in the transport proteins, for example sex hormone binding globulin, increase in HDL, and a decrease in the LDL. Pregnancy, there will be a 50-fold increase in the estradiol and estrone in the pregnancy, because the female is getting fat when she is pregnant. So we know that estrone is being produced by the adipose tissue, right? And secondly, the estradiol is being produced from the ovaries. So ovaries are hyper functioning when the person is pregnant and all that. So this is just a mnemonic, this is not a scientific basis of the thing that I'm just speaking right now. So remember this, that during the pregnancy there is a 50-fold increase in estradiol or estrone, and a 1000-fold increase in estriol, indicator of the fetal well-being, because estriol is being produced in the placenta, and estriol increases the indicator of the fetal well-being. Estrogen receptors expressed in the cytoplasm translocate to the nucleus when bound by the estrogen. So estrogen receptors expressed in the cytoplasm will translocate to the nucleus when they are bound to the estrogen. Okay, estrogen receptors expressed in the cytoplasm translocate to the nucleus when bound to the estrogen. Yeah, because they have to do the transcription stuff. Okay, so here we have the FSH and LH and estrogen inhibition. So estrogen will cause an inhibition of the anterior pituitary and the GnRH release from the hypothalamus, while the inhibin and progesterone will lead to inhibin and progesterone, they cause the negative feedback on the posterior pituitary, no, on the anterior pituitary. They will also lead to inhibition of FSH and LH and also GnRH. So basically estrogen and inhibin, so why they mentioned it differently. Okay, so inhibition is there except for the mid cycle. In the mid cycle, the estrogen release is stimulating the LH surge, while the inhibin and progesterone, they are like constant inhibitors of the GnRH and FSH and LH. I don't know. Then we have theca cell, granulosa cells. So remember that theca cells are the counterpart. The male counterpart of the theca cell is Leydig cells. Leydig cells, and the male counterpart of the granulosa cells are the Sertoli cells. So Sertoli cells. So granulosa cells are the female counterparts of the Sertoli cells, while the theca cell is the female counterpart of Leydig cells. So remember this one. Now what is that? LH or luteinizing hormone will bind to the LHR receptor on the surface of, what is that? On the surface of, I guess, these theca cells. Yeah, they are binding to the theca cells. So in the theca cell, they will cause ATP to be converted into CAMP. CAMP will convert the cholesterol into androstenedione. So theca cell are responsible. So tell me that what the Leydig cell is responsible for doing in the males. This theca cells are responsible for the production of testosterone, right? The theca cells are the androstenedione or androgen producing cell of the females. Like theca cells will cause the production of androstenedione. That androstenedione, if due to some reason there is overactivation of the theca cells, and the granulosa cells cannot perform the function, like in the PCOS, PCOS, like polycystic ovarian syndrome. Yeah, PCOS. So in the case of PCOS, the theca cells are hyper functioning, and that leads to virilization in the females. Like the females will develop male pattern hair distribution, of male baldness, and muscle girth increases, stuff like that. So the point I want to make is the theca cells are going to receive signal from the luteinizing hormone, and they will start producing the androstenedione, that is an androgen. Now that androstenedione will diffuse into the granulosa cell, which are under the theca cells, and those cells will lead to conversion of androstenedione into estrogen by the enzyme aromatase. That estrone will then be converted into estrogen, and there is a reversible cycle between estrone and estrogen. So remember that, and this is how the estrogen is being produced from the follicle cells of the ovary. So inside the ovary, we know that there are follicles, and the structure of the follicles, the outer rim is formed by the theca cells, and the inner cells are the granulosa cells, and both of the cells will act in unison. Both layers are acting in unison to form the estrogen. How? The LH will bind to the theca cells to cause the production of androstenedione from the cholesterol by the enzyme desmolase. That androstenedione will diffuse into the granulosa cells by the enzyme aromatase. Estrone will be formed, and that will be converted into estrogen, and that estrogen is then released into the circulation, and then it will be performing its role. And the very important point that we were about to miss, that the granulosa cell aromatase activity is enhanced or stimulated by the FSH when FSH bind to the FSH receptors on the granulosa cells. So we have FSH receptors on the granulosa cells, while we have LH receptors on the theca cells. Remember? I hope it is clear. So I want to mention one more point, that we remember from this that LH, if we go to the male physiology, so luteinizing hormone was stimulating the Leydig cells, right? Luteinizing hormone was stimulating the Leydig cells to produce testosterone. Now, since theca cells are the counterpart of the Leydig cell, the female counterparts, so in the female body, luteinizing hormone will stimulate the theca cells, and they will also be producing androstenedione, that is an androgen. Okay, end of the story. Now we'll move to the next one. The Sertoli cells are present in the males, which is stimulated by the FSH. So FSH stimulates the Sertoli cells in the males. Since the granulosa cells are the female counterparts of the Sertoli cells, so the FSH will stimulate the granulosa cell in the female, and there they will start producing estrogen. Okay, so the functionally they are different, but the hormonal stimulation is similar for both of these cells. So here you can see it is a flow sheet diagram that cholesterol is converted to androgens by luteinizing hormone in the theca interna, synthesis of the androgens, right? And the progesterone will also be released. In these androgens will then be converted into estrogen by FSH stimulation of the granulosa cell, which contain the aromatase. Okay, so here you can see this, like the theca internal cells, the theca external cells are just a structural support, they are not doing anything. The theca internal, the green cells, they contain the desmolase, while the granulosa cell, they contain the aromatase and the reaction we have just already studied. Now moving forward, theca externa is the connective tissue capsule. So moving forward, as we're done with this, estrogen receptors expressed in the cytoplasm translocated nucleus and bound to the estrogen. Now we have estrogen synthesis. So cholesterol will be converted to pregnenolone. Pregnenolone will be converted into 17-hydroxypregnenolone, and then we have DHEA dehydroxy epiandrostenedione. Yep, and that will be converted into androstenedione. Androstenedione can be converted into testosterone, which by the effect of aromatase will be converted into estradiol, and androstenedione can directly convert into estrone to the estradiol. So this is basically the pathway that is taking place inside the adrenal cortex. I don't know the exact layer. I guess it is happening in the I don't remember it. I don't remember the name of the layer, but it is basically happening in the adrenal cortex. So if there is any problem with this one, with this chain, we will study that in the endo section inshallah tomorrow. So if there is any problem with this particular condition, with this particular pathway, so the person will develop, the fetus will develop congenital adrenal hyperplasia. Okay, moving forward, pardon me for that. Progesterone. Progesterone, the source is corpus luteum, placenta, and adrenal cortex and testes. So corpus luteum, placenta, adrenal cortex, and testes, these are the sources of progesterone. Fall in the progesterone after delivery disinhibit the prolactin, and that leads to lactation. So progesterone is an inhibitor of the lactation, right? So fall in the progesterone after delivery disinhibits the prolactin, and that leads to lactation. Progesterone is indicative of ovulation. If there is an increase in the progesterone, this means that their ovulation has taken place. Progesterone is progestation and prolactin is prolactation. So progesterone is progestation, yes, and prolactin is prolactation, and they are antagonizing each other's effect as well. Then we have function, stimulation of the endometrial glandular secretion and spiral artery development. If there is a picture of that, maybe the picture is like this one. So the spiral artery formation in the secretory phase is mediated by the progesterone. If you can see this, the progesterone level is high in the secretory phase, and that is causing the spiraling of the artery in the secretory phase, but we will discuss that when we will come over here. So here you can see maintenance of the pregnancy. So stimulation of the endometrial glandular secretion and the spiral artery development, that is mediated by this progesterone. Then maintenance of the pregnancy, because initially it is formed by the corpus luteum, then placenta starts producing its own progesterone, and then the adrenal cortex and testes are producing some amounts of progesterone as well. So the maintenance of pregnancy is happening by the virtue of progesterone. That decreases the myometrium excitability and uterine smooth muscle relaxation, that is preventing the contractions. Decreased estrogen receptor expression prevents the endometrial hyperplasia. It decreases the estrogen receptor expression, and thus it prevents the endometrial hyperplasia. Production of the thick cervical mucus. So production of thick cervical mucus, which inhibits the sperm entry into the uterus. So if it is producing thick cervical mucus, so there will be inhibition of the sperm entry to the mucus. So that is why it is also used in the oral contraceptive pills. Secondly, the purpose of using it in the OCPs is like different. I am just telling it that it is one of the functions maybe, but it is just to remember that since it increases the thick cervical mucus, so it inhibits sperm entry to the uterus, and what I was talking about, I just forgot about that. Okay, let's leave it. So it also causes an increase in the body temperature and inhibition of the gonadal dropping, that is LH and FSH. Okay, endometrial hyperplasia and stuff like that. Okay, then we have oogenesis. So let's discuss this diagram first. So again, here you can see oogonium is a diploid cell, just like the somatic cell of the body. It is 2N, 2C. I'm not explaining that now. 2N means it has like a pair of chromosomes. So 23 pair of chromosomes are present. That means 2N, 2 times the number of chromosomes, and 2C means that it has 2 chromatids for each chromosome, right? Then primary oocyte or diploid will become 2N, 4C. So initially, just before entering the meiosis 1 or prophase 1, it will become 2N, 4C. That is, there is a pair of chromosome, and each chromosome is now a bichromatid or dichromatid chromosome. So the total number of chromatids for each chromosome will be 4. So a total of 96 chromatids or 46 sister chroma. That is not right. It must be 46 sister chromosomes or 92 sister chromatids. right? It's not correct. Let me cross check it over here. Yeah, as you can see here, it is 92 sister chromatids. So there is a misprinting in this picture. So it is 92 sister chromatids, and then we have secondary oocyte. This is not 42, this 46, this is 92. So remember that. Then we have so these cells, thus the primary oocytes, they are arrested in the prophase until ovulation. So it is an interesting knowledge that all of the primary oocytes that will be ovulated throughout the life cycle of a female, they are being produced during the intrauterine life. So these oocytes which are being formed during the intrauterine life, they are arrested in the prophase, and they remain in the arrest until the ovulation starts, right? Until ovulation. So until ovulation they remain in the prophase 1. As soon as they are ovulated, they complete their meiosis 1, and secondary oocyte is haploid 1n, which means that it has half the number of chromosomes, but it is still double chromated. Now this secondary oocyte becomes arrested in the metaphase until fertilization, right? Now until fertilization, so there is some difference as well. So the oogonia will divide into primary oocyte. Primary oocyte will give rise to a secondary oocyte and a polar body. Polar body can degrade and give rise to two polar bodies. So basically this is an insignificant cell. Okay, this is something that can become ovum. So it is arrested in the metaphase until fertilization. As soon if it gets a sperm, if it does not get a sperm, it will die as such, arrested in the metaphase. But if it gets some floating sperm, as soon as the sperm touches the secondary oocyte, it completes its metaphase 2, and it completes its second meiosis and becomes ovum, that is 1n and 1c, and then the fertilization takes place, and then it becomes a zygote, that is 2 and 2c. Okay, so I hope it is clear now. So this is replication, then we have meiosis 1 and meiosis 2, and now let's read the text. In the female, gametogenesis begins early in the embryonic development at approximately 4 weeks of gestation. Okay, gametogenesis begins early in the embryonic development at approximately 4 weeks of gestation. Primary oocyte begin meiosis 1 during the fetal life and complete meiosis 1 just prior to ovulation. So it can remain arrested in the prophase 1 for years. Meiosis 1 is arrested in prophase 1 for years until ovulation, primary oocyte. Then meiosis 2 is arrested in the metaphase 2 until fertilization, that is secondary oocyte and egg metasperm. If fertilization does not occur, within 1 day the secondary oocyte degenerates. So now you can see that its ancestors, which are like the primary oocyte and the secondary oocyte, they were waiting there for years. The oogonium of the primary oocyte, they could wait for years, but the secondary oocyte is like very hasty, so it cannot wait so long. So if within 1 day the sperm does not come, it becomes very angry, and in that anguish it just undergoes apoptosis and it degenerates. So moving on to the ovulation. So ovulation and menstrual cycles, so there are two types of cycles, the ovulatory cycles and the menstrual cycles. So I guess it is wise if we just take a snapshot of this picture. Yeah, okay. I hope this will work for us. So let's make it small, and bring it to our page. So here we were talking about the oogenesis, and then we are talking about ovulation. So increased estrogen, increased GnRH receptor on the anterior pituitary. Ovulation happens because of increased estrogen. So whenever there is increased estrogen, that will cause an increase in the GnRH receptors on the anterior pituitary. Okay, estrogen surge then stimulates the LH release. So estrogen in the mid cycle causes an LH release that leads to ovulation and rupture of the follicle. So let's see this in the picture. So here you can see that estrogen is depicted by this blue line. So estrogen is estrogen is depicted by this line, the dark blue line or the black line basically. So the estrogen is rising in the start of the, so listen. This is ovarian histology, this is endocrine cycle, and then at the bottom we have the endometrial histology. So this is endocrine cycle. So you can call this is something that is happening in the blood, this is happening in the ovary, and this is happening in the uterus. Like it is, this picture is divided into three halves: the ovarian events, the blood events, and then the menstrual or the uterine events. So this is ovarian cycle, this is the menstrual cycle or the endometrial cycle, and in the middle we have the hormonal pictures in the blood. So keep this in mind that this black line is representing the estrogen. So during the development of primary follicle, then secondary follicle, then vesicular follicle, we have previously studied that estrogen is being produced by the follicles. So now when there are follicles, so estrogen is being produced. As the follicle is maturing, the more and more estrogen is being produced. Initially, estrogen is suppressing the FSH and LH. As you can see, as the estrogen is increasing, like as it is rising, the FSH is falling down, the purple line, and the sky blue line, that is also kind of at the baseline level. It is not increasing that dramatically. But as soon as at the 14th day, when ovulation is happening, or when it is close to the ovulation, when the cell is close to ovulation, the increase in estrogen level causes a LH surge, and we will see the mechanism of that as well, because nothing that is happening is increase in estrogen at this level causes an increase in the GnRH receptor in the anterior pituitary, and that increase in the GnRH receptor lead to an increase in the LH surge. That LH surge causes ovulation. Then LH level also falls down, and the estrogen level is also falling down. Now along with the LH surge, you can see an FSH increase. So basically the increased estrogen level at this particular phase is causing an increase in the GnRH receptor placement on the surface of the anterior pituitary, and that increase in the GnRH receptor will lead to the stimulation of LH and FSH in a pulsatile fashion. If not pulsatile is not the right word, it is just a rapid shower of LH and FSH that is coming into the circulation. That will cause ovulation. Then estrogen level falls down, and then there is a second peak. I don't know why, but there is a second peak, and then the progesterone level, it remains like undetectable throughout the follicular phase of the ovary. Ovarian cycle can be divided into follicular phase and the luteal phase. So throughout the follicular phase, the progesterone is not detectable, but in the luteal phase the progesterone is detectable. One reason is that the progesterone is being produced by the corpus luteum. So since the corpus luteum is formed in the luteal phase, so it is also corresponding with the increase of progesterone in the luteal phase. And as soon as the corpus luteum is regressing into corpora albicans and stuff like that, so progesterone level is also dropping down, and after that, by the end of the cycle, all of these hormones achieve their baseline level, and then the new cycle starts. And in the meanwhile, when we have the follicular phase, the follicle is maturing. Initially the menses take place, and then by the 14th day the estrogen causes hypertrophy or increase in the tortuosity, not tortuosity per se, but increased glandular hyperplasia in the endometrium. After ovulation, the progesterone causes the spiraling of the arteries, and it increases the secretion and everything that is important for the conception. So progesterone is progestation, so it is going to cause the spiraling of the arteries and all that. Estrogen was just making the making hypercellularity, was increasing the hypercellularity within the endometrium. So these are the things that you must remember, and further details we will be studying when after 2 to 3 pages when this picture comes. So estrogen surge then stimulate the LH release, ovulation, rupture and follicles. Increased temperature, progesterone is induced. So whenever there is increased temperature, there is progesterone induction. Progesterone induction is causing an increase in the temperature. So basically the temperature increases at time of ovulation. That is very important, because whenever we are doing the non-pharmacologic measures of contraception, so one of them is basal metabolic rate, basal body temperature, BBT. So that basal body temperature is a thing that a female is asked to record the temperature, her body temperature throughout the month, and whenever the temperature increases, this means that this is ovulation has occurred. If she wants to conceive, she must have intercourse in that particular time, and if she does not want to conceive, so she must wait for at least 2 to 4 days of that rise in the body temperature, so that the ovum dies out, and then it is safe to have sexual activity. Then what is that? Mittelschmerz disease. It is a transient mid-cycle ovulatory pain, or called Mittelherz or Mittelschmerz pains, common in the women who are not taking OCPs, who are ovulating. So it is common in the women who are not taking OCPs. That is a buzzword, that is a code word for saying that the women who are not ovulating, due to who are ovulating, I'm sorry, the women who are taking OCPs, they are not ovulating, but the women who are not taking OCPs, they are ovulating. So that is why they can have middle Schmerz pain due to the enlargement of the developing follicles which irritate the peritoneum. For example, the follicular swelling and rupture and fallopian tube contraction. So all of these things can irritate the peritoneum, and that can lead to middle hurts or abdominal pain. It can mimic the appendicitis, so it can look like appendicitis. It is not appendicitis, but it can look like that. Uworld point is ovulation predictor kit measures the urinary LH and becomes positive 24 hours after ovulation. So ovulation predictor kit is that it measures the urinary LH and it becomes positive 24 hours before ovulation. Oh, so it is a good thing that you are measuring your LH, and before 24 hours before ovulation it will become positive, and then you know that what do you have to do. You can decide it then. So your ovulatory predictor kit measures the urinary LH and becomes positive 24 hours before ovulation. After this, we will talk about the menstrual cycle. So the menstrual cycle, follicular phase can vary in length. So you know that the follicular growth that can vary in length. It may take different time, but the luteal phase is 14 days. So if I could zoom this picture like this. So the follicular phase, it can vary like in days. Variation can occur in days, but the luteal phase, like after ovulation till menstruation, the luteal phase, it is fixed. It is 14 days. So it helps us calculate the menstrual cycle and the time of ovulation, stuff like that. So since it is fixed, what is the significance of that? Ovulation plus 14 days is equal to menstruation. So whenever the ovulation takes place, we can measure that with the ovulation kit. So whenever the ovulation takes place, plus 14 days is equal to menstruation. Follicular growth is fastest during second week of follicular phase. So it is fastest during the second week of the follicular phase. Estrogen stimulates the endometrial proliferation, that is growth. So estrogen is going to cause endometrial proliferation and growth. So as we saw here, that the first phase, the proliferative phase, this one, the proliferation was mediated by the estrogen, and that was causing the proliferation of the estrogen. And then we had the secretory phase over here. So the secretory phase is like progesterone maintains the endometrium to support the implantation by stimulating the secretory activity. Progesterone withdrawal leads to menstruation. So whenever there is progesterone withdrawal, as you can see, by the end of the cycle the corpus luteum degenerates and the progesterone level falls down, so the menstruation starts. So remember that. Then just give me a second. So yes, ovulation predictor kit, we did that, and now we've done the progesterone maintains the endometrium and supports the implantation by stimulating the secretory activity. Progesterone withdrawal will lead to menstruation. Decreased progesterone will lead to decreased fertility. Whenever there is a decrease in progesterone, the fertility level will also be decreased. A Uworld point is progesterone released by the corpus luteum causes the uterine glands to coil and secrete the glycogen-rich mucus in preparation for the embryo implantation. The glycogen-rich mucus in preparation for the embryo implantation. The endometrial stroma becomes edematous and completely traversed by the tortuous spiral arteries that extend from the deeper layer of the uterine lumen. So this is very important for your step exam, because they will tell you either about a glycogen-rich or maybe a thick mucus. So they will ask you that what are the phase, what are the menstrual cycle, what is the phase of the menstrual cycle right now. So you have to tell them it is the luteal phase or luteal phase of the ovarian cycle and secretory phase of the menstrual or endometrial cycle. And another thing that they may ask you is that which hormone will be elevated, so that is progesterone. So keep these things in mind. These are like free points, so bonus points. So here you can see that ovarian tertiary follicle is looking something like that. So in the center we have nucleus, okay, then surrounding that we have zona pellucida, then corona radiata is surrounding that, and then here are the theca cells. Theca externa cell are mere connective tissue cell, while the theca interna cell are containing the desmolar enzyme, and they are responsible for the production of for the androgens basically. Then we have the antrum, then the fluid filled cavity, then the granulosa cells. They contain the aromatase enzyme, and those aromatase enzyme are responsible for the conversion of the androgens into the estrogen. And then the first polar body is present, like if you could see that, like in the middle. So that is the first polar body, and this is the secondary oocyte. Okay, then here we have seen the cycle before, so I guess we have no need to go through that again. So the ovarian histology: primary follicle, secondary this is vesicular follicle, like the one with the vesicle is called the vesicular follicle. Then we have the ovulation, and then corpus luteum degradation, and the corpus albicans, follicular phase, luteal phase, and here we have the endocrine hormones, So FSH, LH, and here we have the luteinizing hormone over here, and then the progesterone is over there. Okay, then we have the proliferative phase and the secretory phase. Endometrial histology is over here. Then we have the menses and the cycle days at the day 14. Proliferative phase. Proliferative phase can be estrogen driven and it increases the glands and stroma. So proliferative phase is estrogen driven, like proliferative phase, like this phase over here. It is driven by the estrogen, and there will be an increase in the glands and stroma. Secretory phase, like this one. So the secretory phase is progesterone driven and it decreases the proliferation. Secretory vacuoles appear, so it decreases the proliferation. The secretory vacuoles will appear, and prominent spiral arterioles can be seen. Like these are the prominent spiral arterioles over here. These can be seen in the picture. Then we have the mid proliferative phase of the endometrium at day 7. So this is the mid proliferative phase, the one which is dictated by the endometrium. So you can see the arteries or the glands, like they are straight, like this is the artery. So this is not that tortuous as these arteries, as you can see in this picture. So these are very tortuous arteries. So mid proliferative phase, endometrium, day 7. The endometrium demonstrates uniform development with a gland stroma ratio of less than 1:1. So that the gland to stroma ratio is like 1:1 or even less than that. So the gland stroma ratio is less than 1:1. Okay, the glands are straight and narrow and contain small humors. I'm reading it here. So in the case of mid secretory phase, endometrium, day 21, the gland to stroma ratio has increased to approximately 1:1. So the stroma, like this thing, the interstitium you may call it. So the stroma to the gland ratio, the circle things, so that has become like close to 1:1, because the amplified stromal volume is associated with a marked stromal edema. The glands are dilated and coiled and contain wide lumens. So they are wide, and like in the case of proliferative phase they were like straight glands, but in this case they have wide lumens and they are tortuous and stuff like that. So effects of FSH on the menstrual cycle. So now we will talk about effect of FSH and effect of LH on the menstrual cycle. Let me bring the picture back. Okay, so here are two pictures. Like this one is the one which we are already discussing right now, and this is from the next page. So we are trying to discuss or decode the effect of FSH on the menstrual cycle. Following the onset of menstruation, FSH stimulates one or more dominant follicles to form in one of the ovaries, that is follicular phase. Normally it is one of the follicles, but it can also cause these to form in two follicles in both of the ovaries, and in that case it will lead to a dizygotic twin and stuff like that, the paternal twins. So we are talking about the normal or usual cycle. So in that case, the effect of FSH on the menstrual cycle is following the onset of menstruation, FSH stimulates one or more dominant follicles to form in one of the ovaries, that is follicular phase of the ovary. If I could highlight this picture, so you will be able to appreciate the follicular phase over here. So as you can see that FSH is kind of started rising over here, and that helps in follicular phase by stimulating the growth of the follicles. Okay, then the FSH also stimulates the estrogen production from the ovaries. So FSH was stimulating the So FSH was stimulating the estrogen production from the ovaries. As the follicular phase advances, a progressive rise in the serum estradiol is seen. High estrogen level in the late follicular phase have a positive feedback effect on the LH production, resulting in an LH surge. So FSH caused the follicular production inside the ovaries. Got it? Now those follicles started producing estrogen, and estrogen is inhibited to the FSH. So FSH level, as you can see in this picture, started decreasing as the follicular phase is proceeding. Right? As the follicular phase is proceeding, the FSH level is falling down while the estrogen level is increasing. Got it? Now the second thing that you must keep in mind is that during the mid cycle, the increased estrogen level has a paradoxical positive impact on the LH cycle, and the LH surge takes place. Now what happens is the increased level of estrogen causes an increase in the GnRH receptor production on the in the anterior pituitary, and that increased level of the GnRH receptor leads to the overproduction of LH and FSH both. So you can see that along with the FSH, along with the LH surge, there is a small increase in the FSH as well. So both of these hormones are increased. So this is the effect of FSH on the menstrual cycle. Like that's it. So let's see this picture as well. So here you can see that FSH leads to the developing, it stimulates the development of the follicles. So FSH stimulates the development of follicles. So it started from here, hypothalamus, a pulsatile release of the GnRH. A pulsatile release of GnRH led to the positive stimulus to the anterior pituitary that causes the FSH and LH production. The FSH will stimulate the development of the follicles. Those follicles will start producing estrogen, and those estrogen will lead to the decrease in the FSH levels. And then in the mid cycle, Due to the increase in the estrogen, there is an LH surge. Along with that, we have an increase in the FSH level as well, and then FSH again comes back to the baseline level. So these things must be kept in mind. Then we move forward. So effect of the LH on the menstrual cycle. So effect of the LH on the menstrual cycle. Ultimately, the LH surge causes the rupture of the dominant follicle, leading to the extrusion of ovum or ovulation, while the rest of the follicles will degenerate. So ultimately, the LH surge causes the rupture of the dominant follicle, leading to the extrusion of an ovum. Failure of ovulation, for example, the anovulation in the polycystic ovarian syndrome (PCOS), is a common cause of infertility. If there is no ovulation, like suppose this is an ovary, and follicles get matured. Okay, there are a lot of mature follicles inside the ovary, but they just don't get ovulated. There is no rupture of the follicle and there is no release of the ovum. Resultant a syndrome develops that is called the polycystic ovarian syndrome (PCOS). Treatment options include the administration of the drug that act like FSH and LH. Menotropin, human menopausal gonadotropin therapy, mimics the FSH and triggers the formation of dominant ovarian follicles. So menotropin, that is the human menopausal gonadotropin therapy, mimics the FSH and triggers the formation of a dominant ovarian follicle. When the follicle appears, mature exogenous human chorionic gonadotropin is administered. The alpha subunit of the HCG is structurally similar to the LH and therefore stimulate the LH surge by inducing the ovulation. What's that? I don't know. Treatment options for the PCOS include the administration of the drug that acts like FSH and LH. So they can be menotropin or HCG analogs. So menotropin is the human menopausal gonadotropin. Therapy mimics the FSH and triggers the formation of dominant follicles. So if we are giving the menotropin, so menotropin will lead to the formation of the dominant follicle. So there will be follicular growth and then there will be development of some dominant follicle and stuff like that. And when the follicle appears, mature exogenous human chorionic gonadotropin (HCG) is administered. The alpha subunit of HCG is structurally similar to LH and is therefore stimulate the LH surge by indicating ovulation. So it will stimulate the LH surge by inducing the ovulation. How come? Because when we are giving the human chorionic gonadotropin, it is an analog of LH. So we are basically giving exogenous LH surge, and that exogenous LH surge will cause ovulation to take place. So these two treatment options can be used for the treatment of the polycystic ovarian syndrome (PCOS). Menotropin and gonadotropin, human chorionic gonadotropin. Menotropin will mimic the action of FSH, while this one, like the human chorionic gonadotropin, will mimic the action of LH. Then these are the phases of ovulation. Let's study that in detail now. Okay, so the first phase is the human hypothalamus. Hypothalamus will lead to a pulsatile release of the GnRH. That pulsatile release of the GnRH is causing release of FSH and LH from the anterior pituitary. This is the phase. Okay, so due to that FSH and LH release, many primordial follicles which were present in the ovaries, some of them will start developing into mature follicles, right? The developing follicle, as the follicle starts developing, it produces estrogen, and that estrogen decreases the level of FSH. So there are three spikes to estrogen, like one, and then there is another, then there is another. So remember, they give you a graph like this, and then they ask you to identify the graph with a very minimum level of information. So you have to go with the peaks. So count the number of peaks, and then that will give you the answer. So if it has 3 peaks, so it is estrogen. So let us try to make some lame mnemonics for that. So if it is like 1, 2, 3 peaks, so it is estrogen. Then that estrogen will cause a decrease in the level of FSH and LH, but during the mid-cycle, there is a rapid surge in level of LH and FSH as depicted over here. LH and FSH both are increasing. After that, once the ovulation is done, the luteinizing hormone and the FSH level, they come back to the baseline levels. And in the ovary, what happens is that ovulation took place. Then after the rupture of the dominant follicle and ovulation, the remnant of the follicle becomes corpus luteum, and that starts producing progesterone. And then we have, when it degenerates, like it becomes corpus albicans, then we have progesterone level falls down and the menstruation starts. So here you can see the estrogen level increasing, and once the LH surge is there, it decreases, and due to some unknown reasons, I don't know, maybe the corpus luteum is producing estrogen, so that estrogen level also rises by the end of the menstrual cycle. Okay. For the progesterone, you must remember that there is only a single peak. It is not seen in the follicular phase or the proliferative phase. The follicular phase of the ovarian cycle or the proliferative phase of the menstrual cycle, there is no progesterone. right? Because the progesterone is produced by the corpus luteum, that is found in the luteal phase of the ovarian cycle, and that corresponds with the secretory phase of the menstrual cycle. Okay, so progesterone level increases. So if you the graph of the progesterone looks like the inverted P. So progesterone, P is for the progesterone, and the graph is also looking like something like this. So with a single spike, so that is progesterone, and these are the two graphs that you must keep in mind. And then there is also graph for the inhibin one, which is not mentioned over here, but Dr. Nandan Joshi in his video, go and check Dr. Nandan Joshi. He has also made like first 22 read with me sessions, and they are like pretty good. They're pretty good. So just go and give them a check. So then we have like phases of uterine cycle. So here we have menses, so like the bleeding and shedding of the endometrium. Then we have the proliferative phase. Proliferative phase is followed by the ovulation that lead to the secretory phase, and then we have the menses. So we have discussed that like a lot of times now. And then we have anovulatory cycle. So what does that mean? Menstrual cycle without ovulation is called as anovulatory cycle, as the name implies. No ovulation, so there is no corpus luteum formation, and if there is no corpus luteum formation, absence of the luteal phase of the ovary, there is no progesterone. Excessive endometrial growth from estrogen. So there will be excessive endometrial growth from estrogen because progesterone is inhibitory to the progesterone is inhibitory to the what that is. Progesterone is inhibitory to estrogen. So if estrogen is not inhibited, there will be excessive endometrial growth. Unopposed growth from lack of estrogen can lead to irregular bleeding and dysfunctional uterine bleeding. That is also, I guess it is called as dotting or something. I'm not sure. I don't know. So irregular bleeding can be seen because the effect of estrogen are unopposed. Common at menarche due to the underdeveloped hypothalamic pituitary hypothalamic pituitary ovarian axis HPO. Hypothalamic pituitary ovarian axis is immature. So at the advent of menarche, it can happen like this. Then menopause due to the loss of ovulation, and thyroid disease, that is obesity. So thyroid disease, that is obesity. Uworld point. Anovulation is common in the first several years after the menarche and the last few years before menopause. So anovulation is common when in the first several years after the menarche and the last few years before menopause. It manifests with a marked menstrual cycle variability. Imperforate hymen. We are not in the pathology section yet. Pathology section is still like a lot of pages away. I don't know, but let's talk about imperforate hymen. So imperforate hymen is obstructive lesion caused by the incomplete degeneration of the central portion of the fibrous tissue and tissue band connecting the walls of vagina. So here you can see that in the vagina, normally there is a protective layer covering the vaginal orifice, that is called as hymen, but there is a central perforation to that, and that central perforation is allowing the menstrual blood to come out of it. But in some cases, it is not the fibrous tissue is not perforated, and that is called as imperforate hymen. Presentation at birth. Vaginal secretion stimulated by the mother's estrogen may cause accumulation of the mucus in the vaginal canal, mucocolpos. So vaginal secretion stimulated by the mother's estrogen may cause accumulation of mucus in the vaginal canal, which may manifest as bulging introitus. If undiagnosed, mucus reabsorbed and child asymptomatic under menarche. So at birth, why can it happen? The pathogenesis is that vaginal secretion stimulated by the mother's estrogen may cause, so the mother estrogen will cause the fetal vagina to start producing secretions, and those secretions will lead to accumulation of the mucus within the vaginal canal of the fetus, and that will result in a mucocolpos. Like it is, mucocolpos means that the one thing is mucocolpos that occurs in the fetus, and then another thing is hematocolpos. So mucocolpos means there is accumulation of the mucus within the vaginal canal which cannot be extruded out. So that is called as mucocolpos. Colpos basically means accumulation of the fluid in a sac, that is colpos. So mucocolpos means that there is accumulation of the mucus which may manifest as bulging introitus. So the introital bulging will be seen something like this, I guess. But this is hematocolpos, and something on those lines will be seen in the case of mucocolpos as well. So at puberty or menarche, patient may present with a primary amenorrhea. Normal secondary cycle characteristics will be there because everything is normal. Only the only thing is that hymen is not perforated. Cyclic abnormal or pelvic pain, cyclic abdominal or pelvic pain due to the accumulation of the menstrual blood in the vagina and uterus, that is hematocolpos, resulting in the pressure may cause back pain or difficulty defecating. Examination may show vaginal bulge with possible mass palpated anterior to the rectum. So So there will be a possible mass that is palpated anterior to the rectum. Along with that, examination may show vaginal bulge and stuff like that. So hematocolpos, and this is bladder. Then pubic symphysis is over there. So then urethra and hematocolpos, imperforate hymen is over there. So it was supposed to leak out, but it cannot come out because of the imperforate hymen. So it is accumulating inside. And then we have the rectum. So if we do the DRE, so a mass can be palpated just anterior to the rectum. And this is the picture of hematocolpos. Both of these pictures are taken from the Uworld question bank. Then Uworld point is primary amenorrhea in the context of normal ovarian and anterior pituitary gland function is termed as eugonadotropic amenorrhea. Suggests the presence of an anatomic defect in the genital tract. The two most frequent causes are imperforate hymen or Mullerian duct anomalies. So there can be Mullerian duct anomalies as well. On top of that, there can be imperforate hymen. The Mullerian duct anomalies were those which we discussed, like the didelphys uterus, and there was didelphys uterus, there was bicornuate uterus and stuff like that. So that was the Mullerian. Those were the defects with the Mullerian duct. I guess yes, these are the Mullerian anomalies uterine. So they include the septate uterus, the bicornuate uterus, and the uterine diadelphys. And these are, like, normally it must be a triangular shaped uterus, but in this case it is in the septate we have a Y-shaped uterus, X-shaped uterus in the case of bicornuate, and completely separate uteruses, and two cervices, even two different vagina, two separate vagina can also be seen in these cases. So let's come back. So here we have imperforate hymen. Then there is pregnancy. Let me check the time. So we're done with this session, and we will start the pregnancy in the next session. Until then, Allah Hafiz, fi amanillah.